Okay, thank you very much. So good afternoon, everybody. Uh, Although I'm joining remotely from Japan, it is a great pleasure to speak out to my colleagues in India. Thank you very much for your kind invitation. My topic is something we all use every day, fluorescein. Fluorescein is often considered a simple staining dye. However, I believe it tells us much more than simply whether staining is present or not. Okay, this is my file. According to Asia Dry Eye Society, dry eye is diagnosed by symptoms together with tear film instability. Tear film instability is therefore central to dry eye diagnosis. Fluorescein remains one of the simplest and most practical methods for evaluating this instability. It is simple, but very informative. DO3 recommends non-invasive TUT whenever it is available. However, these devices are not available in every clinic. If we look closely at this figure, Fluorescein TVT is still included with a cutoff value of less than 5 seconds. Fluorescent staining is also included as an ocular surface marker. So fluorescent stain remains clinically useful even in the DO3 era. I'd like to introduce a concept that was originally developed in Japan. Tear film-oriented diagnosis and tear film-oriented therapy. We call TFOD, T-fold and T-fold. This approach has now been incorporated into the recommendation of the Asia Dry Eye Society. The basic idea is very simple. Instead of treating all dry eye patients in the same way, we identify which component of the tear film is deficient and tailor the treatment accordingly. ADES categorizes dry eye into 3 types: aqueous deficient dry eye, decreased wettability dry eye, and increased evaporation dry eye, based on abnormality in tear film or epithelial surface. In aqueous deficient dry eye, target component is aqueous. In decreased wettability dry eye, target component is membrane-associated mucin. In increased evaporation dry eye, target component is lipid. Interestingly, the new DO3 framework and the default concept are actually very similar. Both aim to identify the underlying driver of tear film instability. So I think these actually concepts from ADES and DO3 are well aligned. T-fold is a diagnostic approach that helps us identify which component of the tear ocular surface may be insufficient. Based on the fluorescent breakup pattern, we can classify dry eye and better understand the underlying abnormality. Let me explain with movies. So area break usually indicates severe aqueous deficiency. Fluorescein fails to spread upward because tear volume is remarkably reduced. You can imagine the severe aqueous deficient dry eye usually associated with Sjogren disease. This is line break. Line break represents milder aqueous deficiency. Line break is diagnosed as a vertical line-like shape during upward movement of fluorescein at the lower part of the cornea, within which fluorescein intensity is decreased with time until the cessation of upward movement of fluorescein. Now let's move to decreased wettability dry eye. Spot break appears immediately after eye opening. This pattern reflects clear membrane-associated mucin deficiency, indicating impaired epithelial wettability. Dimple break represents a milder form of decreased wettability. Dimple break is diagnosed as an irregular but vertical line-like shape during upward movement of fluorescein within central part of the cornea. Again, the key problem is epithelial surface quality rather than tear volume. Okay, finally, let's move to increased evaporation. Random break is diagnosed as an irregular and indefinite shape and occurs after the cessation of upward fluorescein movement. After every actually movement. Breakup pattern, a breakup location differs species or each ring. It usually related to lipid layer abnormality. So simply observing the breakup pattern already tells us where to start treatment. Fortunately, obtaining these findings is actually very easy. Only 3 points are important. Number 1, use the minimal amount of fluorescein. Number 2, shake off excess solution. Number 3, apply gently. No special equipment is required. Even in the dew-free era, this simple technique provides valuable clinical information. When we use fluorescein, our eyes tend to go straight to the cornea. I always remind my residents, please don't forget the conjunctiva. In many patients with dry eye, conjunctival epithelial damage appears before corneal staining. If we don't look carefully, we may miss an important finding. I'd like to introduce the blue-free barrier filter. Interestingly, the term blue-field filter was coined by my professor, taking inspiration from the red-free filter using glaucoma. Technically, it is simply a yellow barrier filter. When used together with the covert blue filter, it greatly enhances the visibility of fluorescein staining, particularly subtle conjunctival epithelial staining. It's a very simple modification, but it makes a surprisingly big difference in daily practice. The staining distribution is also informative. Dry eye usually shows greater conjunctival involvement, whereas drug toxicity often causes dominant corneal staining. This simple observation helps differentiate the two conditions. And please always ask patients exactly how often they use eye drops. Sometimes the treatment itself becomes the cause of the ocular surface damage. I have seen patients using artificial tears 20 or even 30 times per day. So actually the treatment is to stop the causative eye drops and use only stain. Another practical tip is not to overlook hidden areas. Averting the eyelid often reveals abnormalities that are otherwise missed. Some like SLK, conjunctival crisis, foreign body, and post-operative eyelid surgery. This patient was superior limbic keratoconjunctivitis, or SLK, which is often associated with dry eye disease. Initially, the corneal, nasal, and temporal conjunctiva appears almost normal. However, after averting the upper eyelid, you can see the fluorescein staining. Without examining this hidden area, the diagnosis could easily be missed. Another condition that benefits from careful fluorescein examination is conjunctival crisis. This is a common and often frustrating ocular surface condition. Fluorescein clearly highlights the staining on the redundant conjunctiva, where mechanical friction occurs with every blink. This finding helps us understand why these patients experience persistent irritation and pain. So this patient was referred to us with suspected keratoconus. Looking at the placido topography, you might think there is something wrong with the right eye. There is also an obvious difference in the amount of astigmatism between the two eyes. So keratoconus seems like a reasonable diagnosis. Actually, however, corneal tomography was completely normal. The abnormal placido topography map was caused by tear film instability and an irregular corneal epithelium. In other words, this was showed irregular astigmatism rather than keratoconus. This is another case. At first glance, this looks just like tear film breakup. On the right, you can see a map-like pattern, and on the left, a fingerprint pattern. But there is one important difference. Unlike tear film breakup, these dark areas do not move after eye opening. The dark areas could easily be mistaken for dry eye. This tells us that the abnormality is in the epithelium rather than in the tear film. So is this direct dry eye? The diagnosis is epithelial basement membrane dystrophy, or EBMD. EBMD is frequently overlooked. Without fluorescein staining, the diagnosis can easily be missed. Many patients are asymptomatic. However, they may become symptomatic after ocular surgery, especially cataract or refractive surgery. Recognizing EVMD before surgery is therefore very important. A simple fluorescein examination can prevent postoperative surprises. I'd like to conclude with three take-home messages. First, fluorescence remains highly variable even in the DUS3 era. Second, fluorescence regular pattern provides important clue to the underlying mechanism of tear film instability and help us appropriate treatment. And finally, this is my main message of today's talk. Fluorescein is much more than a staining dye. It allows to look beyond staining and better understand ocular surface homeostasis. Thank you very much for your attention.
You so much, Shizuka. I think that was very illustrative. So I always feel and always say that you should always do fluorescein staining because that changes your diagnosis completely. Dr. Sirish, would you want to comment on this?
Yeah, no, I think she has covered most of it, and fluorescent staining is a very important aspect in dry eye management. So there are various grading systems that can be followed, and we can assess the severity of dry eyes. The one is the Oxford grading, and the second one is the National Eye Institute grading, and this will give us the idea about the severity of dryness, and she has covered even the other causes for staining of cornea, which has to be differentiated, and the treatment actually differs. And like foreign bodies underneath the upper palpebral conjunctiva, or drug toxicity, and of course, in a very severe case of dry eye toxicity and severe dry eyes where the entire cornea is staining, may be a little difficult to differentiate, but the treatment remains the same in these cases.